Hello and welcome for this web conference of the Filière FAI²R. I am Noémie JOURDE-CHICHE. I am a nephrologist at Aix-Marseille University and Assistance Publique Hôpitaux de Marseille, and we will discuss today what's new in the treatment of lupus nephritis. These are my conflicts of interest. So, as you may know, lupus nephritis is a frequent and severe involvement of systemic lupus erythematosus, with a risk of end-stage kidney disease of 10 to 30% at 10 years, and the risk of cardiovascular morbidity and mortality. With standard therapies, currently we can achieve 30 to 80% of remission according to the population studies and to the definition criteria used. And there is a risk of relapse, which requires maintenance immunosuppressive therapy to be continued. Difficulties of treatment adherence and drug-related adverse events lead us to try to think of the decrease of treatment. Unfortunately, we lack of prognosis criteria to predict which patient is likely to evolve to chronic kidney disease or is likely to relapse. New therapies have been approved recently in Europe in lupus nephritis, namely belimumab and voclosporin. Lupus nephritis can have a broad variety of injuries, from mesangial hypercellularity to diffuse lupus nephritis, such as here in class 4 global and active lupus nephritis, or crescentic glomerulonephritis, podocyte injury, tubulointerstitial lesions, and vascular lesions. Lupus nephritis impairs patient survival, and in the Europe lupus cohort from 1990 to 2000, lupus nephritis was the main risk factor for mortality. When we examined SLE patients deceased in France between 2000 and 2009, there was a strong increase in the mortality of patients younger than 40 years, especially in case of renal disease. Lupus nephritis, of course, impairs also the kidney survival of patients. It was 90% at 10 years in the Euro lupus cohort and SLIC cohort, and in a recent international meta-analysis from 1975 to 2015, the renal survival was 85% at 10 years. And you can see here that this survival at 5 years, 10 years and 15 years, we're looking here at the risk of end-stage kidney disease at 5, 10 and 15 years, has been decreasing until the 2000 years and then has remained stable or even increased a little afterwards. And in patients with class 4 lupus nephritis, up to 30% of end-stage kidney disease at 10 years can be observed. Recent recommendations have been published by the KDIGO and the joint EULAR and ERA-EDTA. What they state is that the final objective of treating lupus nephritis is to preserve kidney function and reduce chronic kidney disease-related morbid mortality while limiting toxicity of treatments. These recommendations for class 4 or 3 lupus nephritis with activity, whether there is an associated class 5 or not. They state that it relies on corticosteroids with either IV cyclophosphamide or oral MMF, followed by a maintenance therapy. And there are some alternatives using anticalcinorins such as tacrolimus and MMF for the ERA-EDTA, or adding belimumab to MMF or cyclophosphamide, or tacro or voclosporin to MMF, or rituximab to MMF or cyclophosphamide, especially in refractory disease, or azathioprine in pregnant patients. For class 5 lupus nephritis, treatment mostly depends on the degree of proteinuria, and only patients with nephrotic syndrome or heavy proteinuria with a UPCR above 3 grams per gram for the KDIGO or above 1 gram per gram for the ERA-EULAR, despite RAS inhibition at a maximum dose for more than 3 months will require immunosuppressive therapy with either MMF or cyclophosphamide or CNI or azathioprine or rituximab. The first novelty of these recommendations is the doses of corticosteroids. Here we look at the dose for a patient who weighs 60 kilograms, and we have the initial oral corticosteroids up to 1 milligram per kilo, 60 milligram, down to 20 milligram per kilo for the reduced ULAR ERA doses, possibly with initial IV pulses of methylprednisolone for the KDIGO or for the European recommendations, and then a progressive decrease in the doses of oral corticosteroids and below 5 milligram per day at 6 months or even earlier. Second novelty is that these recommendations defined the response that was expected with treatment. And this response is that we should expect an improved or stabilized eGFR within a range of 10 or 15% and urinary protein to creatinine ratio objectives. So for the KDIGO, the initial UPCR should be reduced at month 2 by 25%, and complete or partial remission should be achieved between M6 and M12, complete remission being defined by a UPCR below 0.5 gram per gram, partial remission being defined by a reduction of 50% and less than 3 gram per gram UPCR. And this can be achieved a little bit later, from M18 to 2 years, if progressively this UPCR is getting lower and lower. And if this is not attained, we could repeat kidney biopsy to see if there are persistent active lesions that should require treatment reinforcement. For the European recommendations, UPCR should be decreased by 25% at 3 months, 50% at 6 months, and below 0.5 to 0.7 at M12. And also it can be a little bit later if the patient was initially nephrotic and is currently improving. And an emphasis is highlighted on the necessity of extrarenal remission or low disease activity state. So now we have also new therapeutic options in lupus nephritis, especially targeting CD lymphocyte B survival and differentiation into plasmacytes and lymphocyte T activation. The first option is belimumab, which is a monoclonal humanized antibody directed against B lymphocyte activating factor. And the main trial was in lupus nephritis was belimumab BLISS-LN. Patients were included if they had class 3, 4, or 5 lupus nephritis with a kidney biopsy within 6 months and a UPCR of more than 1 gram per gram. They were randomized between belimumab and placebo, in addition to MMF or cyclophosphamide and corticosteroids as an induction treatment. Then for the maintenance therapy, they continued belimumab or placebo, in addition to either MMF if they had been induced by MMF or azathioprine if they had been induced with cyclophosphamide, and corticosteroids which were to be lowered below 10 milligram per day at 6 months. And the primary criteria was primary efficacy renal response at 2 years, which was defined by a UPCR below 0.7 gram per gram with no eGFR decline of more than 20% and no need for rescue therapy. And this endpoint was reached in 43 versus 32% of patients in the belimumab versus placebo group. Concerning complete renal response, it was also more likely in the belimumab group, 30% versus 20% at 2 years. Belimumab was associated with a lower risk of renal-related events, and these renal-related events were mostly increased proteinuria or impaired kidney function or both. And there was a lower risk of renal relapse after 6 months. There was a lower risk of kidney function alteration. This study was published afterwards. It was a post-hoc analysis of the Bliss-LN study. A lower risk of eGFR decline of 30% or 40%. And in the subgroup analysis, there was no proven benefit in patients with class 3+5 or 4+5 or pure class 5 lupus nephritis. No benefit in patients with nephrotic syndrome, and no benefit in patients who had been treated with cyclophosphamide and azathioprine. The second therapeutic option is voclosporin, and voclosporin is a calcineurin inhibitor which blocks the transduction signal of T lymphocytes. It was shown in the Aurora-1 study. Class 3, 4, or 5 lupus nephritis patients had to have a kidney biopsy of less than 6 months or less than 24 months, but with a doubling of UPCR in the past 6 months. They had a UPCR of more than 1.5 gram per gram, and they were randomized between voclosporin 3 caps B daily versus placebo 3 caps B daily, in addition to MMF 2 grams per day and corticosteroids with 2 IV pulses, and then low-dose corticosteroids. Patients were below 6 mg per day at 2 months and below 3 mg per day at 4 months. And the primary endpoint was complete renal remission at 1 year, which was defined by a UPCR below 0.5, a GFR above 60, and less than 20% eGFR decline with no need for rescue therapy, and a possibility to maintain corticosteroids below 10 mg per day between week 44 and 52. And this rate of complete renal response at 12 months was 41% in the voclosporin group versus 22% in the placebo group. And there was a rapid UPCR reduction in the voclosporin group, possibly as expected because it is an anticalcineurin, a calcineurin inhibitor with also a vasoconstriction and hemodynamic effect and stabilization of the podocyte cytoskeleton. But this effect, as we will see, was also maintained on the long term. So there was no specific safety alert, even if there were more hypertension, more AKI, more reduced eGFR, more headache or tremors. This was handled by reduction in the doses of voclosporin that were defined in the protocol. And there was no proven benefit in patients who were not yet on MMF at randomization, who were of white ethnicity, or who had pure class 5 lupus nephritis. The long-term outcomes were studied in the Aurora-2 study, for which the publication is awaited. So it is a 2 more year study, so patients are treated for a total of 3 years, and that included 216 patients out of the 357 patients initially randomized in Aurora-1. And there was, after Aurora-2, no eGFR decline at 3 years, and there was a persisting effect of lowering of proteinuria. And after a washout period of 4 weeks, there was no rebound in the proteinuria after treatment discontinuation. Concerning maintenance therapy in class 3 and 4 active lupus nephritis, maintenance therapy must be individualized based on the speed and quality of remission, on the duration of flare-free remission, extrarenal SLE activity, and patients' preferences. That's the statement of the European and American and international recommendations. Maintenance is based mostly on MMF from 1 to 2 grams per day, or azathioprine, especially in patients who wish to become pregnant, or possibly with calcineurin inhibitor according to the KDIGO. The duration of maintenance therapy is still a matter of debate. KDIGO state that it should not be less than 3 years, and that weaning can be discussed if there is a complete remission, renal complete remission and low disease activity state for the extrarenal SLE activity. And the European propose to continue maintenance therapy for at least 3 to 5 years and discuss weaning after the discontinuation of corticosteroids. We published in 2022 the WIN lupus trial, which showed that there were more severe flares if immunosuppressive therapy was discontinued after 2 to 3 years. Yet, the majority of patients who discontinued therapy after 2 to 3 years and continued hydroxychloroquine did not flare, which suggests that some patients can be weaned. We need to better identify those patients who are at low risk for relapse. And possibly we could help ourselves with repeat kidney biopsies to better identify patients at risk or at low risk of relapse. And for corticosteroids, they are mainly dedicated to extrarenal SLE activity, and weaning can be discussed according to the KDIGO after 12 months of complete remission and after 3 to 5 years according to the European recommendations. So should we repeat kidney biopsy? Up to now, we perform a kidney biopsy at the initial diagnosis for patients who have a UPCR above 0.5 gram per gram. So we perform kidney biopsies earlier than patients who were included in the main trials for belimumab or voclosporin, for instance. We also repeat kidney biopsy for patients who seem to be refractory to treatment, especially to check that the persisting proteinuria is really related to persisting active lesions and is not a matter of chronic lesions. We also perform new biopsies when we suspect that a patient is relapsing lupus nephritis. But for the moment, we did not perform systematic kidney biopsy, protocol biopsy to adjust therapy. And this may be the case in the future, especially to assess a pathological remission and decide whether a patient should be reinforced, whether treatment should be reinforced, or in patients which we wish to wean off treatment, discuss if pathological remission allows for this weaning. I want to finish this presentation by discussing nephroprotective strategies and global care in patients with SLE. Because end-stage kidney disease is multifactorial in patients with SLE and not only related to lupus nephritis activity. So of course, lupus nephritis activity is important, and the absence of remission or the multiplicity of relapses are a risk factor for end-stage kidney disease. But also vascular lesions, acute or chronic, related for instance to high blood pressure, can also participate in kidney function deterioration, and metabolic lesions as well. When we perform several biopsies in a patient with lupus nephritis, we can, for instance, see only active lupus nephritis on the first biopsy. Then we see active lupus nephritis and chronic damage, for instance, on a second biopsy. And finally, if we perform later a third biopsy because kidney function has impaired or proteinuria has increased again, we may find no more active lupus nephritis lesions, but only chronic damage, interstitial fibrosis, vascular lesions, and sometimes diabetic nephropathy. To reduce this evolution to chronic damage and to end-stage kidney disease, we need to optimize nephroprotective strategies with renin-angiotensin-aldosterone system inhibition, possibly gliflozin use as for patients with chronic kidney disease other than lupus nephritis, tobacco weaning, toxic drugs eviction, and diet to avoid overweight, diabetes, hypertension, and also in patients who develop chronic kidney disease, low protein diet to prevent kidney function degradation. And we also need to take care of the patient globally for his arteries and infection and corticosteroids adverse events in particular. So what's new in the treatment of lupus nephritis? Concerning the induction immunosuppressive therapy in active proliferative lupus nephritis, we are now using reduced corticosteroid doses, and we have the possibility of using new approved add-on therapies, belimumab, which is already available in France, for instance, for relapsing patients or for patients with poor renal prognosis. I believe that not all patients systematically need to have add-on therapy such as belimumab, especially when they have a kidney biopsy for a UPCR of 0.5. and voclosporin, which is not available yet in France, and which could be, for instance, useful for patients with a heavy proteinuria or nephrotic syndrome, because it allows a fast reduction in proteinuria. Maintenance immunosuppressive therapy, we need to better identify patients who can safely be weaned, and we need to, in addition to the treat to target strategies already implemented in lupus and lupus nephritis, we need to think to untreat and identify patients for whom the burden of therapy can be lowered. And we may perform more repeat kidney biopsies to assess pathological remission and guide therapy. And this is probably not new, but this must not be forgotten. As for all patients with chronic kidney disease, we should really emphasize the need for reinforcement of nephroprotection, and this could be as crucial as control of lupus nephritis activity to prevent end-stage kidney disease. Well, thank you for listening to this web conference. I hope you found interesting information in it, and goodbye, have a good day.